Hello, and welcome back to the VJHemOnc podcast. Over the past decade, BTK inhibitors have transformed the management of several B-cell malignancies. However, their role varies considerably across non-Hodgkin lymphoma subtypes. In some diseases, BTK inhibitors have become a cornerstone of treatment, while in others, their place in the treatment landscape continues to evolve. In this episode, we'll explore the current and future role of BTK inhibition across several non-Hodgkin lymphoma subtypes, beginning with Waldenström's macroglobulinemia, before moving through mantle cell lymphoma, follicular lymphoma, and diffuse large B-cell lymphoma. This podcast episode is the second of 3 in a Spotlight On podcast series supported by AstraZeneca. This supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. Few lymphoma subtypes have been impacted by BTK inhibition as profoundly as Waldenström's macroglobulinemia. The introduction of BTK inhibitors has fundamentally changed treatment approaches for many patients, offering highly effective targeted therapy and long-term disease control. To begin, Charalampia Kyriakou shares insights into the current role of BTK inhibitors for treating Waldenström's. Stephen Treon discusses how BTK inhibitor therapy is being optimized to improve clinical outcomes, and Anna Maria Frustaci comments on salvage treatment strategies after treatment failure on a covalent BTKi.
I think the brutal kinase inhibitor products, subsequent generations as well, have really transformed the life of our patients, because don't forget that these patients are of quite variable age. We have quite a lot of older age group of patients. This is oral therapies as well. That is very good for patients' quality of life and to get on with their life with acceptable toxicity of these agents in using them in the WM practice. In UK now we have license to use BTKi inhibitors as second or further line. The agent that is licensed and we can use is zanubrutinib, and this is giving our patients the chance to keep going with good quality of life and good response for prolonged period as well. That will become increasingly a hot topic in our pathway of treating the WM patients, because obviously we have the chemoimmunotherapy in the first line therapy, and then we have the BTKi inhibitors. We're looking forward for the results from the BCL2 inhibitors or combination of BTKi with BCL2 inhibitors that in some countries is more accessible rather than others. And also in this treatment pathway, we cannot completely exclude recycling old-fashioned therapies, or in a very small selected subgroup of patients, even considering getting these people into response with old-fashioned therapies and going to autograft based on their performance status and fitness or eligibility criteria to move on to this type of therapy.
So when we look at BTK inhibitors as a single agent, they're the most active, class of agents. Now, of course, trying to optimize these has been very important. We don't see with BTK inhibitor therapy complete remissions, which tells us that there are alternative pathways of survival, some of which we've defined, and I'm sure many others that we still have to sort of work on. But we don't see CRs, and this tells us we can do better. We've tried combining BTK inhibitors with BCL2 inhibitors. There's currently a trial that we're fully enrolled on, combining pirtobrutinib with venetoclax. That's actually looking promising in the relapse refractory setting. When we tried to do this with ibrutinib, combining venetoclax and ibrutinib, we actually saw ventricular fibrillation, and we had to abandon that trial. So all these combinations are not going to be safe, and it is really important for our viewers to understand that. There's currently also a trial combining zanubrutinib with sonrotoclax. This is still proceeding. And so we're gonna learn about BCL2 combinations and perhaps, integrate this sort of, strategy into a fixed time limited therapy. But the ones right now, the trials that I would be looking at with great excitement are the combination of bendamustine Rituxan with BTK inhibitors. There's a trial in Canada, the BROM study, combining acalabrutinib with benda-R that looks wonderful. We're seeing MRDs there. There's a trial in China that, has just also concluded, combining zanubrutinib with bendamustine Rituxan. A lot of MRDs there too. We're very excited about that data. And in the US, we're doing a trial with zanubrutinib and benda-R. These are slightly different trials because in the US, we're trying to minimize bendamustine Rituxan exposure, whereas the trials in China and in Canada are doing 6 cycles of bendamustine Rituxan. We'll see what the results are. We're actually over-enrolled on that trial, so we're really looking forward to presenting. All this data actually will be presented in Palm Springs in October at the 13th International Workshop on Waldenström. So stay tuned, more to come.
Okay, this is a great question because the salvage treatment after covalent BTK inhibitor in Waldenström macroglobulinemia is really an unmet clinical need. We don't have a well-known strategy to treat these patients. We just know about phase 1 and phase 2 studies. So at the moment, we can use as salvage treatment non-covalent BTK inhibitors. This is supported by the Bruins trial that explored patients with Waldenström. A cohort of patients we previously treated with covalent BTK inhibitors that responded well to pirtobrutinib. We have about 22 months progression-free survival in the whole cohort, so including exposed and not exposed to covalent BTK inhibitor. But of course, this is an effective strategy because we know that patients that relapse with BTK mutation, covalent BTK inhibitor may respond to non-covalent BTK inhibitor. Another strategy could be the BCL2 inhibition. This was explored in a phase 2 study from the Center of Boston with the venetoclax monotherapy. But there are currently some ongoing trials also with sonrotoclax, that is a next generation BCL2 inhibitors. And also this pathway could be an effective strategy for patients relapsing after covalent BTKI.
While BTK inhibitors have become firmly established in Waldenström's, their role in mantle cell lymphoma continues to evolve, and the emergence of novel targeted approaches is prompting important questions about how BTK inhibitors should be positioned in the future. In this section, you will hear Krish Patel, Manali Kamdar, and Tycel Phillips discuss the current role of BTK inhibitors in mantle cell, the shift of these agents to the frontline setting, and therapeutic approaches being considered for patients who relapse on these agents.
So a lot of things happening in mantle cell, and I think a big one, as you highlight, is the shift of BTK inhibitors towards frontline therapy. So we've seen both in younger and older adults combinations of BTK-containing therapy, typically with chemoimmunotherapy. So in younger adults who historically would have received intensive chemotherapy and potentially a transplant, now have long-term or longer-term follow-up from the Triangle trial, which I think helps us to recognize that incorporation of BTK inhibitors may help us to avoid the need for transplantation in standard risk patients. I think an area that's still maybe controversial is what to do in patients who have high-risk disease factors. The Triangle data follow-up is still relatively short compared to other transplant trials, but nonetheless, outcomes are better by incorporating a BTK inhibitor into that upfront intensive chemotherapy and potentially in the maintenance setting as well. For our older adults, where historically we might have been using bendamustine-based chemotherapy alone, we have the results from the ECHO trial, which again show us that incorporation of a BTK inhibitor does improve progression-free survival. And so I think across the spectrum, we're seeing that incorporation of BTK inhibitors in frontline therapy for mantle cell lymphoma across a variety of risk groups can improve outcomes, and that's specifically for covalent BTK inhibitors. And I think many of our studies have demonstrated that there are differences in the covalent BTK inhibitors, in particular in terms of toxicity profiles. So we tend to prefer second-generation covalent BTK inhibitors like acalabrutinib and zanubrutinib. The ECHO trial I mentioned incorporates the use of acalabrutinib with BR, whereas the Triangle study was done at a time where ibrutinib was more widely used. So I think at least in the U.S., there's been a shift towards replacing ibrutinib with covalent second-generation inhibitors like acalabrutinib and zanubrutinib because of their more favorable safety profile. And certainly in the relapse setting now, if we're shifting towards more use of covalent inhibitors up front, it begs the question is what would be the appropriate agent in the relapse setting? And I think that's an area where we're still trying to define exactly what will happen. And that'll be a little bit dependent on how BTK inhibitors were used in the frontline setting. Were they used in continuous therapy models where they use this fixed duration, but an area for continued investigation?
So initially, when covalent BTK inhibitors got approved in relapsed mantle cell lymphoma, I think we got a fresh lease of life for those patients who had relapsed with mantle cell lymphoma, but then quickly were able to also see that patients who progress with lymphoma after having been exposed to BTK inhibition with covalent inhibitors did not have very high survival. So in order to improve upon those outcomes, I think we now have two ways to tackle that. Number one, the question was maybe we could bring BTK inhibitors up front. And from that standpoint, the Triangle study in the young, newly diagnosed mantle cell lymphoma, where you incorporate BTK up front, and the ECHO study, which incorporates BTK up front for transplant ineligible newly diagnosed mantle cell lymphoma, showed a higher PFS benefit compared to standard of care. In the young population, we are able to get rid of an autotransplant and just supplement chemo with the BTK inhibition. In the transplant ineligible population, we have seen that chemotherapy plus a BTK inhibitor like, say, acalabrutinib actually has a very improved PFS compared to chemo alone. So I think BTK inhibitors, covalent BTK inhibitors, have made a foray into frontline mantle cell. Now the question is what happens for people who relapse. And I think there we have a few agents that are looking very good. From the Bruin study, we do have the reversible BTK inhibitor pirtobrutinib. We do have sonrotoclax, which is a BCL2 inhibitor, just recently gotten approved in relapsed mantle cell lymphoma. And then we have CD19 CAR T-cell therapies. At the ASCO 2026 meeting, we also are now seeing some really assuring data with regards to efficacy as well as manageable safety when it comes to CD20 bispecific T-cell engagers. So I do think that the landscape of relapsed mantle cell lymphoma is looking refreshingly positive.
I mean, I think what we see is, which I wish we had a very clear picture, BTK inhibitors change the tumor because the disease itself is more responsive to agents when they've never seen a BTK inhibitor. Once they've unfortunately progressed on this drug, the responses to agents that are after that seem to be quite less. So, I mean, we look across the IMiDs, BCL2 inhibitors, PI3 kinase inhibitors. We've studied all of them, and they all, unfortunately, don't have durability of response. So as of right now, it seems like venetoclax, the BCL2 inhibitor, is a great partner with the BTK inhibitor. So I do think as we are looking at these other small molecules, how to pair them, toxicity-wise and efficacy-wise, it seems like that is the best partner for the BTK inhibitors. Allows us to maximize the BCL2 inhibitor and then obviously not have as much toxicity as we see when we use IMiDs or when we use the PI3 kinase inhibitors. You know, as we move forward, I think there may be other drugs that pair better with the BTK inhibitor or may not necessarily be impacted as negatively after a BTK inhibitor, such as those T-cell directed therapies. So again, as we get more data in the future, that may help us better sort of sequence these drugs a bit better or maybe alter the sequence based on how some of the data sets come out.
As you have just heard, in mantle cell lymphoma, BTK inhibitors have established themselves as an important treatment modality. In follicular lymphoma, however, the story is somewhat different. Although BTK inhibition has shown promise, its role has been less clearly defined, and investigators continue to explore where these agents may provide the greatest benefit. You will now hear from Alexey Danilov, who discusses why BTK inhibitors have not had the same impact in follicular lymphoma as in other B-cell malignancies, and comments on their current role in this disease. After this, Paolo Strati provides insight into the value of newer generation BTK inhibitors in relapsed refractory indolent B-cell lymphoma, including follicular lymphoma.
You know, follicular lymphoma is a unique lymphoma. Of course, it comes from a general center B cell, and BTK pathway does not appear to be the driver the main driver, at least in the majority of cases of follicular lymphoma. Follicular lymphoma does have its own mutational landscape. Mutations which occur in follicular lymphoma, you know, are often associated with germinal center evolution, some genes which are responsible for epigenetic reprogramming. And so it is different than, for example, mantle cell lymphoma or CLL, which are very B-cell receptor signaling BTK dependent. So follicular lymphoma, not as much. Although BTK clearly contributes to follicular lymphoma cell survival, it often is not the main driver. And however, it doesn't mean that BTK inhibitors cannot be effective in follicular lymphoma. Again, it's a very heterogeneous disease. And in the era of precision oncology, there would be some cases of follicular lymphoma which are more reliant on signaling through the B-cell receptor pathway due to the mutational landscape. And that is illustrated by the success of the Rosewood regimen, which combined zanubrutinib with obinutuzumab in third-line plus follicular lymphoma and resulted in a progression-free survival median close to 2 years. I do think that BTK inhibitors can be good sensitizers, and I do think that is why partially this regimen is successful, as obinutuzumab is obviously a very effective agent in relapsed follicular lymphoma, and it is possible that zanubrutinib somehow enhances ADCC mediated by and complement-dependent cytotoxicity mediated by obinutuzumab. So I think part of it is through the combination. So we'll see what other studies occur in follicular lymphoma and how BTK class moves in this disease. Currently in follicular lymphoma, BTK inhibitors, again, they're used mostly in third-line setting. Often we think about a regimen like Rosewood in patients who are more frail. We have still more effective therapies in follicular lymphoma in third line, such as bispecific antibodies, CAR T cells. And nevertheless, BTK inhibitors do have a role, particularly in older patients, frailer patients who need to start therapy today as opposed to wait for CAR T to be delivered, because that's certainly a much larger process. I also would like to see the next class of BTK targeting agents investigated in follicular lymphoma. And here I mean BTK degraders. There are some BTK degraders which also have immunomodulatory components like lenalidomide. So that particular compound, such as zelebrudomide, would be particularly interesting to investigate in follicular lymphoma, as it sort of kills two birds with one stone. BTK does remain a relevant target, and it also about how you approach it, what kind of combinations you use, what kind of BTK effects you rely on, not just tumor-directed effects, but effects on the microenvironment.
So historically, the BTK inhibitors that we have been utilizing for relapsed refractory indolent B-cell lymphoma has been mainly represented by ibrutinib. Ibrutinib is not a very BTK-specific inhibitor, has a lot of off-target activity, for example, on ITK, or some kinases in tumor-associated macrophages, such as LIN or SRC. What we saw with acalabrutinib is that while similarly to ibrutinib in follicular lymphoma, it's able to interrupt the crosstalk between the follicular lymphoma clone to the B-cell receptor and tumor-associated macrophages to a receptor called DC sign, and overall downregulates pathways of survival in the follicular lymphoma clone. One limitation is that due to the lack of specificity, ibrutinib also negatively impacts the anti-tumoral activity of tumor-associated macrophages. Differently from ibrutinib, second-generation BTK inhibitors such as acalabrutinib or zanubrutinib, and now more recently also non-covalent BTK inhibitors such as pirtobrutinib, being more specific to BTK, they do still interrupt the crosstalk and so have a favorable effect in terms of repolarization of tumor-associated macrophages, but they do maintain a more anti-tumoral phenotype in the latter. So you may argue that more specific BTK inhibitors may not have a direct impact on T cells, as usually the benefit is ITK mediated, but there may be an indirect benefit due to indirect effect on the tumoral clone. We are trying to understand how this can be now integrated in the treatment algorithm for indolent B-cell lymphoma. I want to remind currently there's a BTK inhibitors approved by the FDA for relapsed refractory follicular lymphoma in third line and beyond, and it's zanubrutinib, so a second-generation BTK inhibitor in combination with obinutuzumab. But we hope that our data will also change the paradigm that BTK inhibitors cannot be utilized in indolent B-cell lymphoma and potentially move BTK inhibitors to the frontline setting to enhance the activity of immunotherapy.
The role of BTK inhibitors becomes even more complex when we consider diffuse large B-cell lymphoma. While there is a strong biological rationale for targeting BTK signaling in certain molecular subtypes, clinical results have been mixed, leading to ongoing debate about where BTK inhibition may ultimately fit within DLBCL treatment strategies. To conclude this podcast, you will hear Manali Kamdar share insights into the current and future role of BTK inhibitors in DLBCL.
So, previously we used to treat diffuse large B-cell lymphoma as one disease. And I think over a period of a decade, we now know that it's not just one disease. Initially, it came in the form of an IHC analysis, gene expression profiling that kind of identified DLBCL into either something called germinal center or non-germinal center with IHC. With gene expression profiling, it got differentiated further into germinal center and ABC. We now also know that this is not all that is DLBCL, and we now have molecular profiling that tells us that it's actually divided into 5 different types. And each of these types is actually triggered by a targeted pathway that has the potential to get inhibited by therapeutics. So this is where I do believe that there is a role of BTK inhibition. For example, we have multiple data sets that have shown that non-GC subtypes actually respond quite well to BTK inhibition. When it comes to molecular profiling, the C5 and the MCD subtypes have a signal which tells us that BTK inhibition is very likely going to be very effective. So I do believe that there is a role to explore BTK inhibition in diffuse large B-cell lymphoma, especially in the non-GC and with regards to the molecular profiling in the C5 and the MCD subtypes. I am very optimistic about exploring BTK inhibitors in the right subset of diffuse large B-cell lymphoma. I think we do have some data coming out of the Phoenix study that does establish that ibrutinib plus R-CHOP, for example, in a certain subset, which is the non-GC, did extremely well compared to R-CHOP alone. So I'm looking forward to figuring out how to strategically manipulate BTK inhibition, whether in frontline or in the relapsed refractory setting. I think BTK inhibitors are also very valuable in the fact that they can penetrate the blood-brain barrier. And with that, I think it's important to highlight that MCD and C5 subtypes have a slightly higher predilection to having CNS relapses. We saw that at the ASCO meeting as well. And I think this is where we have immense therapeutic potential to explore these inhibitors a little bit more. So with relapsed diffuse large B-cell lymphoma, I still use a lot of BTK inhibition, especially if patients have CNS relapses and they are a non-GC subtype. I use a lot of BTK inhibitors if patients are dual exposed to CAR-T, CD20 bispecifics, and now have a non-GC phenotype of DLBCL. But I think I'm most kicked about the ESCALATE study. The ESCALATE study is exploring acalabrutinib plus R-CHOP. It's a randomized phase 3 study, and I think it may have a potential to further improve upon the existing survival rates that we have with newly diagnosed patients with DLBCL. So I'm eagerly looking forward to the ESCALATE study. Now, I think rational combinations makes the most sense. We are also moving away from chemo-based regimens. And I think here, an approach that Dr. Jason Weston, the Smart Start, the Smart Stop, wherein the targeting is done by targeted inhibitors and immunomodulators. So the data that we have with acalabrutinib, lenalidomide, rituximab in the upfront setting is very intriguing, seems very promising. You don't really lose a lot bang for the buck if patients are not in a remission and you add chemotherapy towards the back end. So I do believe that there is immense interest in developing BTK inhibitors in DLBCL. It's all about precision medicine, targeting it for the right subtype at the right time.
Thank you for tuning in to this episode of the VJHemOnc podcast. For more expert insights into non-Hodgkin lymphoma, make sure to visit our dedicated lymphoma channel on VJHemOnc.com. Don't forget to follow us on X at VJHemOnc to stay in the loop, and subscribe to our podcast on Spotify, Apple, or Podbean so you never miss a new episode. Until next time.